I always think is ironic, especially when I am a conference participant, that one of the values of conferences is for us to all get together, and yet folks like me make you all stop. So I apologize that I'm stopping all of your fun, and hopefully you will continue to have more time together. I do, as I was talking to folks during this break, and I just wanted to highlight a few more things. And one of the things is that, as we often say in this work, you cannot improve what you don't measure. And one of the areas that I'm really proud of us as a state is that we have moved to have legislation to standardize race, ethnicity, and language data as a state, that we finally have a data warehouse through Connie and the APCD in order to do this work, and that wasn't there 25 years ago. And it is due to the good work of many of you here again in this room, Health Equity Solutions, as well as the Connecticut Hospital Association, our great advocates as Connect, the Ministerial Health Fellowship, again, Come Here Health, and so many others who have not only raised the importance of data, but more importantly, also raised the importance of community voice in collecting data. And we are also fortunate to have a lot of health systems who are committed to that, including Darcy Cobb-Lomax at Yale New Haven and Catherine Reese at Middlesex, as well as some of our peers at Connecticut Children's Medical Center and at Hartford Health Center, who are also listening to community voice, looking at the data and thinking about how we can improve our system. So again, we can't improve what we don't measure, and Linda talked about some of the history, so we need to know the data history in order for us to know where we're going. So again, thank you all for the work so far and the ongoing work. And the last thing I'm going to take privilege to say is that Linda also really talked about having your North Star, your core, as part of this work, and she talked a lot about her family as that. I'd be remiss to not acknowledge my own family who are in the room, so my husband and my daughter who are here, who are my North Stars. When I look at them, I'm working so hard so that my husband can be treated fairly in the healthcare system, and so my daughter has the chance to live her healthiest life, including with maternal health. So thank you all for being my best supporters and my North Stars. So now I am pleased to introduce Chiquisha Kidd. She is the chair of the Connecticut Health Foundation. She is the founder of Kanumi, a health and lifestyle platform for older adults. And previous to her starting this Kanumi, she held executive roles at Delta Dental of Minnesota, the Hartford, and at the Aetna, where we met. She joined the Connecticut Health Foundation Board in 2017 and became our chair, our first female chair, in 2023. Thank you, Chiquisha. So I welcome Chiquisha to the stage.
Good afternoon, everyone. I am excited to be here. I was honored to be asked to participate as part of this program by introducing our panel. And we are often sort of asked, and especially me, because I actually moved away from Connecticut about a couple of years ago, but I still come back, right? People are like, did you fly up here just for this event? Absolutely. And I think that you're seeing the evidence as to why that's so important. I was fortunate enough to be seated at a table next to Pat Baker, her old colleagues Amos and Leo. This is the foundation of this organization. So I just want to remind everyone about the mission of the Connecticut Health Foundation. You'll see it on our website. It says, we are dedicated to improving the health of all Connecticut residents. We focus on improving health outcomes for people of color and ensuring that all Connecticut residents have access to affordable health care. Linda's speech and presentation sort of exemplifies the foundation as to why this is so important, why we have to focus on that people of color aspect of the work that we do. And part of the reason why it's so easy for me to come back every single time I'm asked to be a part of anything related to the Connecticut Health Foundation is this staff. I know that in my notes that were, diligently prepared by Ariel, who is our chief of staff, it didn't include to thank the staff, but I would be remiss if I didn't say how hard this staff works, how organized they are, how amazing they are in preparing us as board members to make very, very simple, easy conversations, decisions to move things forward. Because as Pat said, there is nothing without execution. The strategy is nothing without execution. So I just want to thank the staff. So Tiffany is also a leader that I cannot stop and continue with this conversation without pausing to acknowledge that she took the reins of what was an incredible organization and is taking it to the next level. So as we're looking at how do we affect change, how do we think about, how do we utilize the resources of the foundation, how do we adjust our focus now that we're looking at maternal health? We were having a retreat a couple of months ago, having a strategic conversation about, yes, we have a pot of money, we understand there's an issue, but how do we actually make impact? And she's very much the strategic visionary to lead us in the right direction. So I want to say thank you to Tiffany specifically. Your leadership, especially in the midst of COVID and all the emergency actions that we were able to take, really led Connecticut forward and provided an example to other states. So thank you, Tiffany. So I just wanted to, now that we've sort of grounded ourselves in some of the issues, we understand our mission, we're moving forward, let's change the conversation to say, how can we now think about solutions? And that's what today's panel is going to be all about. I'm thrilled to introduce them. You can read their full bios, as we mentioned earlier, there are QR codes on the tables, and you can pull up their full bios. But we're really going to start talking about how can we illuminate what we can do to make progress. How do we move things forward? Anka Batterino is the executive director of Building One Community, which has a mission of advancing the successful integration of immigrants and their families into Greater Stamford. Camille Burnett is Vice President for Health Equity at the Institute for Healthcare Improvement, where she works on large-scale health system and place-based population health and health equity work. Also, we have, one of our sort of in-house members, our board member, Pat Charmel, who is president and CEO of Griffin Hospital and its parent organization, Griffin Health, and he is a fellow member of our foundation, as I mentioned, as a board member, so thank you for joining us, Pat. Unfortunately, we lost one panelist. You see Marcela Nunez-Smith is on the program. Unfortunately, she's ill and couldn't make it with us today. But we are finally going to introduce Usha Lee McFarland, who's going to be moderating this panel discussion. She is a national science correspondent for STAT, where she covers health disparities and the intersection of race and science and healthcare. And if you follow the Foundation's weekly health news roundup, I'm sure you've read many, many things stories that she has written. So I just want to thank the panelists for joining us and turn it over to Usha so we can have a robust conversation about solutions.
Hi, everyone, and thank you. I'm so honored to be asked to moderate this panel with these amazing speakers. As Chanika said, I'm a journalist. I feel really privileged. I'm not just a health reporter that occasionally covers health disparities. Health disparities is my entire beat. So I can really dig in and look at many of the problems and increasingly solutions that I see. But it means I spend a lot of time looking at what's wrong and what needs to change. And so I think it's wonderful to be at a place and celebrating something that is going right. And so with Leo's encouragement, I want us all to stand up and let's clap and even cheer for the Connecticut Health Foundation and all the incredible work they've done. All right. He wanted us to be the loudest ballroom in the convention center, and I think we succeeded. Okay. So, there's a lot of panels like this. probably been hundreds, maybe thousands, where people get together and just kind of rehash the problems. It's the same in journalism. So many stories are just this disparity. Black women get more breast cancer, Black men get more prostate cancer. And it's kind of become this churn and noise. And I think we really do need to break through and talk about things differently. And so I want to start with Camille. Like, you are so busy, you have to jet right off from here to another meeting. Same with Patrick, just almost arrived just a few minutes ago. Why are you here? You're not even from Connecticut.
That's so true. And honestly, first of all, hi everyone. It's so nice to be here, and it's an honor and a privilege to be invited just to be in this space to celebrate with all of you. So, when I got the invitation to come, I take these things very seriously. And I think it's an important imperative for all of us to be engaged in part of the conversation. I'm originally from Canada with a family that is Jamaican immigrants. And I've come to the United States as an adult. So I experience a lot of the conversations here in a different context, in a different way. But I say that to say, regardless of the context that I'm used to and I had, been socialized and grew in, coming to the United States was an answer of a call. I answered the call, and I said I would come to help, and I would be here, and I would be present. So I've never felt it was a choice to do these things. I felt it was a responsibility and a moral imperative to be here, because we all need to, it's an all hands on deck moment. I believe this is an existential threat to all of us. And we are beyond crisis at this point in this country. And so we can sit back and continue to admire the problem. And as you talked about it, call it swirl. Or we can roll our sleeves up and say, let's get in on it. How can we be involved? How can we be engaged? So if I have some small sliver of a role to play in that, whether it's in Connecticut or wherever I may be privileged to be called to speak at, or to offer some insights or some solutions to really make some true structural significant change in this country, I will be here time and time again. So I'm never too busy to do that, and I'm never too busy to be here with all of you. So thank you for having me.
It's beautiful. And Anka, how about you? What drove you to be here, and what's important to you at this moment that we find ourselves in?
So I'm delighted to be here. First, congratulations of 25 years of impactful work. We're thrilled to be partners with you. I work for, as it was mentioned before, Building One Communities, a nonprofit dedicated to support the immigrant community. And our mission is about integration, but integration is from language to workforce development, but it's also healthcare, right? And we were talking what keeps me up at night. And in a state that is so wealthy, and there are, 2019, we're 113,000 individuals who are undocumented. That means that, over 60% of them are underinsured or are not insured. The other ones are underinsured. When it goes to the children, to 24 and younger, is even higher. In spite of that, as of July 1st, we're going to have Husky for children up to 15. When I think about all these people in a place where we have the resources, I worry about their everyday lives. At B1C, our lack, I suppose, is to really get to know the community very, very closely. But when you get to know what I always say, the Marias and Mohammeds of the world, you get to understand how their issues are very real for them, right? And how there are so many layers of barriers when it comes to really accessing healthcare, but they also have a lot of barriers of needs, right? And I'll just give you an example, if I may, of a story. We usually have a health fair once a year. We had it yesterday actually, but in last year, it was the first time that we were able to bring a volunteer ophthalmologist to see our people that usually don't get to see ophthalmologists. And there was this Haitian lady who had been in the country for several years. And just to give a projection of what it is, 8 out of 10 women that actually come through the journey in Central America to the United States are raped. 8 out of 10, so let that sink in. This lady was coming to see the eye doctor, and he prescribed her a new pair of glasses. And when she came to pick them up the following week, she took the broken glasses off and said, "These glasses have seen so much horror, and I'm so glad to dispose them." So that's what I'm talking about, the layers. You get to see our community who are really undocumented at best and underinsured. And when you tackle one problem, because of the trauma that they have come through, what you are tackling is a layers of needs underneath.
It's beautiful, thank you. And Pat, how about you? Why are you here today, carving out time to talk about this?
I'm here today because I can't say no to Tiffany. She called me.
Nobody can.
You know, I think Tiffany asked me because maybe I have a unique perspective given the work that I've done with my organization, starting early on as after having some encounters with consumers. We're a consumer-led organization. I work with hospitals and health systems around the world, sort of eliciting the patient perspective, and I've heard a lot. And I've heard a lot in my own organization, and I've seen things. I've recognized that when concerns are expressed, it depends how people look and the color of their skin. Those concerns may be taken differently. I've seen in my own organization, and I've said this before, that I don't like to admit it publicly, I've seen poor outcomes because just based on our perception of an individual, we've responded differently. That set me on a journey to try and change that structurally. I've done a lot of work with our community in a structured way. We've participated in national initiatives like the Accountable Health Communities Project, where we've tried to assess the social needs of our community's residents and not only catalog them, but then respond to them. We serve a pretty socially vulnerable community. During the pandemic, we found ourselves working with the State Department of Public Health to actually address the vaccination needs of the most socially vulnerable communities in the state. And we didn't do that by telling people who live in those communities to come to us. We went to them. We mobilized over 400 caregivers, and we went into communities. And what we noticed more than anything, that there was a lack of trust of the healthcare system. And so we talked about vaccine hesitancy, but it was an underlying distrust of the healthcare system. And that creates a huge barrier. And over a 2-year period, we found ways to break that down. And we found that individuals that lived in those communities began to come to us, not for vaccination because we were there all the time when we built trust, wanting us to address their other healthcare needs. That was really enlightening. And these are the kinds of things that I think we and all of us can capitalize on, but I have to find a way to relay those experiences in ways that are compelling to get us all to act.
Beautiful, thank you. Well, in her incredible talk, Linda talked about the unequal treatment report, came out in 2003. And when I started my beat coming out of COVID, I'm a science reporter, actually, not a health reporter by training, and I like to understand why things work. So I was like, why do these disparities exist? So I wanted to examine that, and I took unequal treatment, also nerd, read all the footnotes. I said, let me do this background reading to come up to speed, like what we knew 20 years ago. And as I got into even, I think, the second chapter, I was like, well, all of these problems still exist. Like they could have written it, 5 minutes ago. So I talked to the authors, the board chair, who's, retired, about, and it was one of my first stories, why has more not been done? If you've ever heard David Williams speak, the amazing health equity scholar, the crisis of premature Black death in this country, if you look at the numbers, it's like a fully loaded 747 crew, fully loaded, crashes every single day. That's the number of lives that are lost that don't need to be. And it's just not a national crisis, right? We don't have Senate hearings. We don't have the effort being taken. Like you said, it's a crisis. So why, let me start with you, Camille. Why isn't more being done? Like, why is this so hard?
Well, you know, one of the things that we say at our organization at IHI, we say the system's designed to give you the results that you're getting. And these results are embedded in the system. And I know that we heard many different ways in which that has happened, but this is structural and this is systemic. It's racialized and it's baked in. That's why. So we need to think about our solutions from many levels. And oftentimes we focus on the individual level. We may go to the community level. We may look at some policies, et cetera. But we really need to address all of the spectrum of that area from beginning to end. So if we start thinking about our systems and structures, we are always trying to retrofit equity into an inequitable system. And we need to design and reimagine our systems so that they're set up for equity and racial justice because they go together. You can't do one without the other. We need to redesign and reimagine our systems and build them that way. So that's the default. And it's in everything you do. And it's not done in a patchwork approach. It's done with coordination. It's de-siloed. There is a common North Star that we're all working towards. And then we need to have specific actions and activities that cross the healthcare ecosystem that we can all see ourselves in and actively start to do.
Right. And Pat, you had mentioned it took 2 years of this effort with the vaccines, and you said, like, what challenges do you come across? What do you think is this going to take time?
You know, one of the things that we noticed, again, I talked about trust.
Yeah.
We had to hire a workforce during the pandemic where everybody was locked down. We were kind of the opposite, going into communities, and it was really important. We realized very quickly that the people who were doing this look like the folks who we're trying to connect with and have the same life experiences. If you look at the composition of the workforce, especially in acute care, there is an imbalance. You know, we started the first hospital-based LPN program in the state. We look at the enrollees in our LPN program, and we know that 75% of our student population are people of color, 25% are white. If you look at the RN population in Connecticut, it's actually reversed. So one of the things we're realizing, if what we learned during that outreach effort during the pandemic, we've got to create now a pipeline for those students that we're attracting into our LPN program to make sure that they now can progress. And by the way, they tend to come from socially vulnerable communities and low-income backgrounds. So not only are we changing the composition of the workforce, we're creating economic opportunity to actually change their lives as well, and their family and their community as well. So that's the kind of thing, as you say, this is very structural.
Right.
So it's not just putting, kind of trying to behave differently. We have to look at the underlying causes. And they're big changes that are hard to do.
One thing I wonder about, maybe Anka you can answer, is has this been siloed too much? Like healthcare needs to fix health disparities. Does this go beyond hospital walls, clinic walls?
So, and I want you to, because there's so much echo that I'm not really
Oh
sure.
yeah, it is echo. I wonder if part of the problem is that we've tasked the healthcare system with fixing health disparities. And maybe we need a bigger army outside of healthcare. Would you say that's true, or what's your experience?
I think it's true, and it's a bigger army of all of us, right? All of us in this room, but beyond that. I look at COVID with one bit of nostalgia only for one thing, and it was the moment where your health was my health too. Today it's not. Your diabetes is yours. Right? But for a moment in time, it was where we all thought we're in this together, right? So I don't think it's just the hospitals, right? I mean, we work very closely with the Stanford hospitals. We train their staff in cultural competency. They come and talk to our people. It's really bringing them to where we are. We work very closely with the FQHCs, right? But I think it's all of us. It's really going back to where we are comfortable, because your health is no longer my health. right? So I think until we get to bring people closer to those who are the victims of health inequities and start to get them to know them, and get their real stories, we're not going to make a change, because I think you need to change public will first in order to change structures at some point.
Definitely. And I want to pause to say we really want this to be a conversation, so we really welcome audience questions. And if you have those, you can just make your way back to the microphone and we can filter them in throughout the conversation we're having up here. So I want to address an elephant in the room, which is, I think with COVID, there was a lot of energy placed in becoming aware of disparities and looking at them and being one. And we really see a fading energy, I think, around racial health disparities and even official pushback. There are certain states where you can't use the word diversity or teach about it. So what do we do when we've just discussed how hard it is to make change? What do we do in this moment when there's both complacency and backlash and a lot of work to be done? Do you want to start, Pat?
Yeah, you're absolutely right. But going back to say we need to think systemically, and these need to be structural fixes. In Connecticut, you have the state of Connecticut now pursuing a new healthcare delivery model and financing system at the federal level that embedded in it is the need to address health equity. That will change the incentives. You mentioned incentives. Currently, the incentives are essentially in the healthcare system, fee-for-service, wait for people to get sick. The sicker the better, and then do a lot of things to them, because that's how we all get paid.
Exactly.
When that shifts and we're responsible, including financially, for the health of populations, we're going to think about how to address those underlying issues differently. So some of these structural things are scary, and I know even me, who I think I'm fairly enlightened, we're concerned because we have a responsibility as a healthcare provider to remain stable and viable, but at the same time knowing that the current incentives are sort of perverse and actually perpetuate the kind of things that we're talking about.
Yeah. Camille?
Commissioner Reeves is there. I don't want to encourage her to be too aggressive in these changes.
Yes, plus one to that, right? All the way, and as well to what you said, Anna, because I think, and I don't know if we're really answering your question, but I'm just going to say, and you can just wheel me back in. I do believe that when we think about our healthcare system, I'm always struck by what we consider health to be, and what is this system? Like, in my orientation, I really think more health as to the point happens beyond the walls of this sacred space that you come into once you are sick. So health starts at home, health starts in the community, and I see the community as the experts in their health. So how do we design and embed that into our thinking around, what do we need to do with this system? I would lean into the course of how are we defining this system? Like, whose system is it? It didn't just create itself. It's people, it's entities, it's culture, it's community, it's all of these things, it's history, it's root causes. So we really need to get up close, to your point, very proximal with that. And I think we can't sort of undermine or devalue the importance of building a relationship. What I find very concerning is, as we're now being incentivized to be doing this work, oftentimes it does feel very extractive and it does not feel bi-directional. We need to have those community relations and partnerships in place, not to get something, just because we need to be aware and to be very close to the community, who are the patients, who are the human beings that we're going to be proximal to. So I just wanted to add that to what both of you said, because I feel that that was a really important point and I didn't want us to miss it. To the other point around pushback, though, that's a very real thing that's happening. In many states, depending on the state, as you know, and not to get political, but health is political. It is, and especially in this country it is, and many other countries around the world. And so oftentimes, depending on what state you are in, There's different levers that you may or may not be able to access, or different things you can and cannot say. We're able to work across different states. We work globally and nationally. And so what I found to be very helpful with that pushback, and that has literally resulted in death threats to colleagues who do this work. This is the level of pushback we're talking about. We're not just talking about not mentioning words. We're not just talking about things where people assume that, if you start talking about race, you're talking about critical race theory, and then that you're trying to teach critical race theory. It's beyond that. It's literally death threats where people have titles that are assumed to be doing something that appears to be threatening. And we know historically why that is, right? And so there's a lot of power and strength in organizing. I think one of the people who spoke earlier, who had a question, said, I want to talk about advocacy. I think that's a really important thing, and it really is. But being in community, being together, all of us sort of marching to the same drum, there's something in that solidarity and in that grassroots mobilization that is very, very powerful. And we've abdicated that power to this institution or to these ways of being, but we own that. It's a shared power space. So I think when we lean into that, we together can start to tackle some spaces of the pushback. We know what's coming, so we need to prepare for that. We need to know how to speak to that, and we need to continue to move forward anyway.
Yeah. Anka, what about you? Do you feel a waning energy around this? Do you feel like you're having to reinvent the wheel to get the work done?
I think so, but again, as an organization working with the community, and I mentioned before that our mission is integration, and to really integrate immigrants into any host society, you need the community at large to be a welcoming one, right? So I think what we work at this level, at the community level, is to work on engagement. We talk about the work that we do, we call it the 4 E's. We empower, educate, and employ immigrants, and we have the 4th E is engagement, right? You really need to engage the community. So I think the pushback comes through many different levels, but one level is also lack of knowledge, right? You fear what you don't know. And by us bringing folks closer to the realities of people, we're trying to tackle, one of these small layers, because when you start to get to know the people by their name, they stop being this monolithic group of Black and brown people over here. They are your friends, or they are the people that you start to get to know their stories. So although we see the push at B1C, I think we are very fortunate to count with 450 volunteers every year, and it's very intentional that we do this, because it's trying to bring that host society to become part of the solution, right? And be catalyst of the problem. And we do that by inserting the knowledge, really understanding those realities on the ground that many of us up here, we don't see, right? And don't really grasp.
I want to get back to power and money, which we were just talking about. It strikes me that some of the most innovative work I've seen in this space are these small but mighty foundations, like the Connecticut Health Foundation, Doris Duke, the Commonwealth Fund. But it's such a big problem. So why are the bigger players not involved? And Pat, do you think, you kind of referred to this, is it going to take carrots and sticks? Like, are people not going to embed equity in their organizations until there's a cost to not doing so?
I think changing incentives will certainly help. I wish that we can all get a dose of humility sort of in my industry. If you look at what actually impacts health, the stuff that we do, and we build big buildings and spend a lot of money on, impacts health only 20%.
That's right.
It's organizations like yours in the community who are dealing with the underlying social drivers of health that have the impact, that can make the change, but they are so under-resourced, right? Thankfully, we have the foundation that can help those organizations, and some of my colleagues from the industry are here, hospitals feel like they're under-resourced, and now we're being asked to sort of create infrastructure to address underlying social needs and to support community-based organizations. Frankly, a little bit of money goes a long way there. if you look at what we spend money on and how much there has to be a little bit of resource transfer. Is that going to be because people become enlightened, or is it because the incentives motivate you to do that? Maybe a little enlightenment and the incentives together could make the kind of change that needs to happen.
Yeah. What do you think, Camille? Carrots, sticks? What's going to work?
You know, I think it's going to have to be a multi-pronged approach. I feel that there's not just going to be one straight path forward, to your point. I think it's carrots and sticks. I earlier had said it's an all hands on deck moment. And as well, I think we have to work together across these siloed groups. So for example, one of the initiatives that is part of the work that we're doing is looking across the ecosystem at the traditional players in this space. So we have payers, we have pharmaceutical biotech research organizations, we have individual practitioners at large, all clinicians. We have professional societies and healthcare organizations coming together in a national coalition towards the same end goal, to transform the healthcare ecosystem, to transform the narratives around health in this country towards equity and racial justice. And so that's probably one of the sort of rare cases where you see all of those different sectors coming together and all of the disciplines coming together, and then as well community-based organizations and community experts all coming together to kind of work along the same thing. And so I feel like it's going to take that type of work. I think there's also going to be a need for us to really start to acknowledge and redress the harms and the history that's there, because until you understand it, and we just got a master class on history and medicine from Linda, but if you're not in a room like this, oftentimes you don't have that. You don't know about that. And so there's a piece of getting grounded, is what we call it. You need to get grounded. You need to understand the roots and the historical witnessing that you're having with the outcomes that you're getting. And then you can start to stand up sort of this coalition, this coordinated action, this collaborative spaces where you can start to move together and share resources, right? We have this group over here applying for money. We have this group over here applying for money. Like, wouldn't it be miraculous if we all came together and did that under the same pot? So we can't have this scarcity mindset that, oh, I need to get it for the work that I'm doing, where all of us are kind of doing this in different disparate ways. And we'd be much more effective pooling this together with some cohesion in some way to be able to mobilize and make that change.
Yeah, that's a really great point. And you mentioned apologizing. Many of you may know the work of Michelle Morse, the Chief Medical Officer at New York City Health and Hospitals, and she feels that that's a big part of this, is healthcare practitioners and physicians apologizing for the racism that has occurred. Do you see that happening? Apology to all the doctors, but I think doctors apologizing, it's not something I see a lot.
I don't think it's just it's redressing, right? It's redressing. It's part of the healing arc, right? You acknowledge, and then you have to redress and act. So it's more than just, we're well-intended people, well-intended organizations, wonderful mission statements. We all want to do the right thing. We don't want to do any harm, but you know what? You have to do good. It's more than just not doing harm. So how do you do good? What does that look like? It's going to look different from organization, from community, from partnerships, et cetera. But there's a redressing that's required so that you can build the trust that both of you have spoken about with those communities, because they're not going to be fooled by listening to the same things over and over again and not seeing any action. So to do that, you have to start behaving different. You have to start doing things different. And the community is such a great starting point to tell you, what is it that we've done and how can we do this better? Where can we start? What's a priority for you? And then start to build it from there. So I didn't mean to interrupt you.
No,
I'm sorry.
Beautiful.
So.
Okay. We have our first question, and again, we'd love to have your questions and hear what you want to discuss here today.
So I think people are going to laugh, but it's Chiki Shakiv, chair of the board of the Connecticut Health Foundation. And Camille, something that you said actually struck me. We're trying to infuse equity into a system that was built inequitably. And that's a real challenge. I think we have a room full of over 300 of us that are doing the work, that are fighting the good fight, where we have this notion that philanthropy should be the solution. I want to ask a little bit of a different question of this panel. And it's getting at understanding that the marketing, and that I'm a business person, so I'm like, we need to do a social media, a PR marketing push for people to understand the history and understand the root cause issues. However, I'd like us to have a conversation about why there is resistance to this change and getting back to the money. So Pat, we were talking a little bit about this yesterday in our board meeting. We know what needs to change. We understand as a collective what those structural changes should be, how the systemic issues need to be addressed. Why is that not being changed? Who do we need to address, and how does money impact the resistance to that change?
She said Patrick.
No, she said we were talking about it. We didn't have the answer. I'm looking to you for the answer.
I'm the community-based organization.
Love that. Nobody wants to touch it, hot potato. So you're right. I mean, I'm going to talk a little bit about like the money piece, but again, this is not the space where sort of I'm mostly involved with, but I think it's an important space because that is that's where the incentives, I believe that, you know, Patrick was speaking about, are really driven. Are we incentivizing towards sick care and sickness, or are we incentivizing toward wellness and equity? And so there has to be buy-in. We talk about this, and it has to be woven throughout all of the aspects of the system. So from the leadership, from the board, we have many board members here. If that's your priority, then that's what we're going to do. It's that simple. And if we decide that we need to look at spaces and places where we can start to say, what is the business case here? Because that matters. Money is a big part of this. Morally, we're there. We've drank the Kool-Aid. We know this is a good thing. This is the right thing to do. It's the business case part that you're speaking to. And how do we make the business case for whatever the return is on investment? And it has been done. There has been calculations done to show you what it's costing us to keep the system here. We saw it today. We're spending more money than any OECD country in the world and getting the worst outcomes. Any business that set themselves up like that, we would have called them an abject failure, but we tolerate that in healthcare, right? And so we have to look at how do we articulate and embed the business case so that we do set up our systems in a ways that we take the return on investment and savings from our upstream care, and then we can say we can reinvest that because it's more cost efficient for us to be upstream than it is for us to be reacting downstream. But you can talk about the numbers, Patrick.
No. So the current system is broken and it's unsustainable, not specifically from a disparity standpoint. You mentioned the fact that in the US, we spend twice as much per capita on healthcare than the average of the industrialized countries. And we have worse outcomes. And we've spent the last 2 decades figuring out ways to move money around, right? As costs have increased, we've come up with new health plan designs, high deductible health plans, right? Which were supposed to be partnered up with employer-funded health savings accounts, but only the largest employers did that. So the burden is now falling on the shoulders of employees who literally cannot afford it. When they're paying 30% of the premium. This is what we talked about yesterday. And then when you're done with your payroll deduction to pay your premium contribution, you're looking at a $3,000 to $5,000 deductible. You're essentially uninsured. That is impacting people's decision about how they impact health. And that payroll deduction is basically depriving them of quality of life. They can't afford their basic living needs. So what's that? Poor nutrition, substandard housing, poor not having transportation. These are the things, if the system is, it's going to force the change. We need to anticipate that that change is coming, and are we going to be in front and try and lead the inevitable change, or are we going to react to it once it happens? I think there's a tremendous leadership opportunity here. And, you know, we talked earlier, people work out of enlightened self-interest. We've got to kind of point this out to them where that return on investment. I've been having conversations with employers.
You have to.
about housing in this state. I mean, think about the fact that housing is not affordable for a large segment of the population. We look at housing, but what is that? How is that impacting everything else in people's lives? You start to talk to employers and they connect the dots, and all of a sudden they say they want to be part of the solution. So we have to build a coalition of stakeholders that haven't been involved in this conversation before. That takes leadership.
Yeah, it was a great question. We have another one?
Hello, everyone. My name is Lucinda Canty. I'm a nurse and a midwife. I've been practicing for 30 years in midwifery this year.
Wow.
So my question, thank you. Thank you. So in the state of Connecticut, white nurses make up nurses are made up of 76.2% are white. 9.4 are Black. Hispanic is 6.0. American Indian is 0.5. That's the state of Connecticut. In midwifery, 90% of the nurses are white. My question is, and I just want to state, is not because we're not qualified to become nurses. It's not because we're not qualified to become midwives. It's because of racism, and we're afraid to name it. We treat racism as if it is immortal. We have policies, laws, and procedures that support that. We have people who put in positions that say they're going to address equity. We have hospitals saying that they want to diversify, but then they don't change. So my question is, how do we hit racism straight on so that we can show people it's not immortal?
It's a beautiful question. Really gets to the heart of things.
Can you repeat some of it? It's really hard to hear.
Get an echo.
I think in general, the question, the speaker laid out some horrifying statistics of how in nursing, midwifery, they're predominantly white fields, and it's not that Black nurses can't do these jobs, it's that they're prevented because of racism throughout training and everything else.
Yes, just to become
So
nurses.
can we address that? And I want to ask, it's so true, one of my investigations showed that only 5% of medical residents are Black, yet 25% of those dismissed are Black. So we talk about a pipeline and everyone's like, we need better STEM education in 5th grade, and yeah, we do, but you also need to stop firing Black doctors right before they're about to, finish. So I guess the question is, as Linda also said, this is about racism, not race. Is that still difficult to talk about? Do people still look at their shoes when you bring it up in a boardroom? I'm not this boardroom, but others. Take it?
Yes. Yeah, they do. I mean, you can feel it in a room when you start talking about racism. You can see the discomfort, you can see the squirming. You can see it. It's palpable. And so, but that doesn't mean you don't talk about it, right? It's not because, well, somebody else is not feeling comfortable, so we're just not going to have this conversation. But it gets back to, I feel like, some of the earlier conversations we've been having up here is, in all fairness, it's important for people to understand racism, because right away it's interpreted like, well, you're calling me a racist, right? And they need to really understand that root cause, the terminology, the narratives, how insidious this has been woven in. And so it's not a blame thing, but that's automatically where that discomfort goes, right? No, I'm a good person. Nobody's saying you're not a good person, right? We're talking about a racist system, and that has racism built in. So yeah, it does happen, and that's the consequence of what you're seeing in terms of the data that that individual just shared with us. So I witness it quite a bit.
How about you, Anka? Does it impact?
Yeah, I'd like to add, for us, again, we serve people from 148 countries, but the large majority are Black and brown folks, right? These are people that the moment that they get here, they are assigned kind of two identities, right? The first one, you are a foreign-born person, and now you deal with that. But the second one is a race identity that for most of them in their home country, it doesn't play the way it plays in America, right? All of a sudden, you are a black person. But when I was in Congo, I was a Congolese, right? So how you deal with that, and then, I think there is a need for a lot of courageous conversations that we're not having, right? Within the immigrant community themselves, right? With Hispanic and Haitians and African Americans in general, because for the community that I serve, this construct is understood completely different depending on where they're coming from, right? And we don't quite understand it when we're here.
Yeah. Pat, how about you? Is it something you can address head on in conversations with employers and other stakeholders? Do you have to tiptoe around it?
It's about describing it. I think once you describe it, I talked about our LPN program. We sort of had this conversation in the hospital, in the boardroom, and saying, look at the composition of the RN cohort and look at who we're tracking to the LPN program. We talked about figuring out ways to facilitate the transition. In fact, I'd love to engage the person who asked the question to be part of our program, because this is an important issue. It's not only figuring out a way to create a pipeline, but it's also to attract people at a younger age. We're actually now working in high schools where we've found enlightened superintendents and educators who allowed us to come into the high school and embed our curriculum into their educational process, so that when kids graduate from high school, they already have 2 or 3 national certification in employable skills, and then we've got them. And then we can put them on the pathway that will change what you just heard. And we're committed to doing that. I haven't heard resistance. I've heard a lot of people who are ignorant that this problem even exists. So I think we have to overcome the ignorance. We have to share the information in ways that are undeniable. You can't just kind of be, you got to be a little bit confrontational about this. You got to be willing to sort of mix it up. And, yes, people's anal sphincter does tighten up when you talk about this. But, sometimes that's when you get their attention.
Okay. That's the quote, if we're running a story about this. That's the quote.
If you don't remember everything else, that's what you'll remember.
Okay. We have another question, I believe.
Hi. Mine is more of a comment. I just want to say that, as a patient and community worker and member, I think the most important thing is to be seen as a human being when I visit my doctor, to not have the person that I trust the most to find what is wrong with me come up with fictitious illnesses and medications to treat me without really trying to figure out what's wrong with me, and to be seen by my doctor. So I also feel that the incentive that will be happening does not give me comfort, because I think that loopholes will be found so that a code can be used, and then medical administrators will still receive the incentive, while people that look like me still die.
Yeah.
Thank you.
Thanks for sharing. I didn't really pick up on a question, but does this idea of not being treated as human,
Oh, absolutely. I think, and this is why it's important to hear from our community. Thank you so much for that, for standing up and saying that, because we really need to center humanity much more in all of our conversations and in our system, because you are dealing with human beings, you are dealing with people, and the more that you can see yourself in the other person, just as a person to person, is the more you see that you have in common than you have that is different. And so just thank you for saying that, and to lift that up, and to remind all of us. And even with the word, when we talk about patient and we say those types of things, it almost doesn't, it paints an othering of like, you're a patient, you're a human being first. So thank you for that.
Yeah. we had a story in Stat yesterday, I don't know if you saw it, but a member of the Four Tops went into a hospital in Detroit under cardiac distress, a history of heart problems. And he said, I'm a member of again, like your dad, Linda, like wanting to maybe get the care he deserved. I'm a member of the Four Tops. They put him in a psych hold. They said, oh, this guy's so crazy, he thinks he's a member of the Four Tops. And didn't treat his heart disease. Yeah, go to Stat, it's incredible. He's filed a lawsuit as he should, but again, the lack of humanity can be shocking. I love it. More questions, we can take the next one.
Hi, Siobhan Hamilton Burgess, founder and executive director of Hartford Health Initiative. So one of the things that I thought about as you were speaking is the constant thoughts of not having enough resources, right? So I have sort of a question or a comment of where we see education's role, right? Because we're constantly increasing resources in order to deal with health disparity and health inequities. But what are we doing with the young people that we can ultimately prepare and empower, right? To take their sort of health, although the system is kind of the way it is and we have people working on that side of things, but really we can't be everywhere all at once. So people have to be prepared to be able to advocate for themselves or have support in order to advocate for them. So that's my question, is thinking, I think, more long-term and where we have an opportunity to change or help to change the trajectory of kind of where we are now, seeing that resources are limited, and the more that this increases, the more resources we'll need, and we won't ever have enough resources to really put a dent into this issue.
Great question. Anka, you were talking about not only the countries you deal with, but all the languages. What are your thoughts on how to empower people more with education to take things into their own hands and improve their own health?
My thoughts on what?
On how to empower people, increase education, increase literacy about health.
I'm sorry, there is a bit of an echo, so sometimes I can't hear them well. We receive people, like I said before, right? Most of them are Black and brown. There are a lot of people with low income and low level of formal schooling. But you get a lot of people that have master's degrees from their own countries, right? And when they come here, they start from zero. They are our janitors, they are our nannies, and so on. There is, because of the work that we do, we had in the past pre-COVID, and we do it to a certain degree still, support our immigrant community to get into the healthcare system. We had a partnership with Norwalk Community College to create a pipeline of folks that would go into home health aides, right? These are undocumented folks that might have a nursing degree back home, but cannot work when they come here. They cannot work for an employer, but they can work in your house, right? So our intention was, how can we get all this population that is here, particularly in Fairfield County, Connecticut is a wealthy state and many people decide to stay home. How can we create a pipeline of people both, that those that can become CNAs and are, right? And those that can not work for a proper employer but can go to our homes, right? So our intention has been to meet people where they are and to support them with the degrees that they already had, or support them to get the degrees here in this country, to learn how to navigate the different systems and connect them to the different employers. We had, this was pre-COVID, but at the beginning of 2020, we called 13 agencies in Fairfield County to see what their issues were to get HHAs and how we could support them. All of them except a couple of agencies in Bridgeport told us that over 90% of their HHAs are foreign-born, right? So this is the population that we have, that we can actually, bring. And in my mind, it was always, we have this very vulnerable population of women, mostly women, Black and brown women, taking care of our other very vulnerable population, our elderly, our sick, and we're not really taking care well of the HHAs who are so poorly paid, right? And we're demanding so much of them. So there is a lot of advocacy work, I think, that we still need to do for some people that are coming into the workforce in the healthcare system that are foreign-born.
Yeah. And any other thoughts, Pat or Camille, on educating patients so people can come in maybe advocating for themselves? Whose job is that?
There is a big role to empower patients and so they can become active participants in the whole decision-making process regarding their care and well-being, but they have to have access to information. And we have not been good as a provider community of providing that information in a timely fashion, in a manner that they can embrace and understand. We haven't listened to the voice of patients. In the work that I do here in the US and around the world, we've held focus groups with 8,000 focus groups with 50,000 individuals across the world to get their perspective. But I can tell you, despite doing that, I'm not sure how much of that perspective is informing the actual care delivery that's happening today. It's great that we're doing it, and I'm probably more enlightened than most. And we're all trying to build patient and family advisory councils, but are we doing it as window dressing, or are we really looking to have that impact care delivery, how we design care, the policies that we set, right? When people identify barriers, do we try and break those barriers down? I think that's the direction that we have to go in.
And before we get to the next, go ahead.
Sorry, about listening to patients, right? And again, I'm going to the population that we serve. These are folks that are fearful of ICE agents, fearful of bringing their own name and so on, right? I tend to see that in surveys everywhere, the population that we serve are always out, right? In focus group, I mean, we work with a number of again, hospitals and agencies to bring that voice, because it's usually one that is out, right? Either because they are very fearful of coming forward, right? They are grateful that they're in this country, they are grateful for the many things, but they're also fearful for their own status, right? Yeah. So oftentimes we end up, and I don't think you can really be the voice of anyone, but at least we're the liaison of these folks that are left out, right?
I wanted to add to that, to both of what was said. I was thinking about that perspective from the responsibility from the provider end. We need to be preparing our providers, all of the clinicians, and those who interact with any people within the system, whether they're patients, whether they're someone who's coming in for a question. We need to actually train and educate and prepare them to be acting in ways where patients are able, or human beings are able, to really articulate and speak. And it's not putting the responsibility, not like the patient can't do that. I think that's important for them to have the power to do that, but we also be able to understand how to share that power with them. And so I feel there's some work that needs to also be done in the preparation stage and our curriculum and the design of that, how we think and talk about culture, humility, how we prepare our providers to really listen intently. And so I feel there's a two-pronged approach to that. I don't feel it's just, well, the patient needs to be a better advocate in a system that's unjust.
Yeah, and I know from work I've done along the southern border on both sides, the education by community health workers is incredible. Yeah. Do we have any community health workers in the audience? Want to raise your hand? And doulas. And the stories I've seen of the impact and the efficacy at such a low cost are amazing. Like, do you have any thoughts, Pat? Like, why don't we have an army of community health workers? Like, I don't know, like the CCC in our country. It seems like it would address so many of these things that we've brought up today.
Absolutely. We're struggling right now with figuring out payment mechanisms and certification criteria, but I think the evidence is already in that community health workers are making a tremendous positive impact. So while we're waiting for the payment mechanisms, I think, as we talked about resource transfer, there are resources that exist that could be brought to bear to build that army that you're talking about. Hopefully we're on the cusp of that. I know that some organizations are doing it, others are kind of taking a more wait and see attitude. But again, we talked about building trust and making those community connections. these are the folks that are going to do it.
Okay, for those keeping track, that's at least one solution to come up with. All right, another question from the audience?
Hi, my name is Lydia Roldan, and I'm a nurse practitioner. Actually, I graduated from the second class of nurse practitioner from UConn, so it goes way back, and being the first minority to graduate from the nurse practitioner there. And thank you. I believe that we need to do some changes within the education of nursing. You were mentioning LPNs, but we have to do some changes at the RN level. If you look at the faculty in our community college and in our universities, minority staff, not adjunct faculty, but the staff, the faculty, I should say. There are very few of us as faculty members. If you look at UConn, I was looking at their list of faculty members. I counted 50, and of the 50 of the faculty members, 4 were minorities. So we have to start at that level. Why? Because if you bring diversity within your faculty, you're going to bring some changes because they're going to bring ideas about the community and how to address the community, how to learn about communities, how to learn about people. You have to learn about their cultures, their beliefs, and really bring it from living it yourself. And that's what I do when I'm in the teaching or either a patient or a student. So I think we have to start at that level. I think we have to start looking at what our faculty, how it's composed within our community college, in our universities, and I think that's going to bring changes from above, from coming down. And until we do that, we can be sitting here and talking about different topics, but nurses are the front line of care. And if we educate them correctly, believe me, it's going to make a big difference in what the outcome of that patient is going to be. Thank you.
Yeah, I think it's really true. I don't know, I'm sure this has been studied in other allied fields, but within medicine, despite all of the discussion of the lack of diversity and affirmative action plans, the number of Black male medical students has stagnated for decades, even gone down. Indigenous male and female, the same. There's been a little bit of incremental growth in others. So what do we do? I've seen analyses that'll take a century to reach parity, right? So we can't wait. And now we have the Supreme Court outlawing affirmative action in educational decisions, which is going to ripple through these attempts to grow a more diverse medical health workforce. So what do we do now? How does that get pushed forward? Any thoughts?
Well, I think when we think about the workforce specifically, and I'm glad that we use the nursing as an example, because that's one that we face nursing shortages as well across the country. And I feel, we talk about pipeline, I tend to say pathways to entering these fields because there's a lot of barriers. And when you think about medical education, what the cost of that is. And if you think about the opportunities from communities that might not have access to the wealth to be able to go to those schools or to be able to afford making some of those payments, et cetera, we need to look at the whole totality of all of the different barriers that get us to the point of we do not have enough representation, whether it's in medicine or nursing, et cetera. And so part of it is I think we need to starting to look at all of the barriers from early on in the pathway before they even enter into the school and start sort of aligning the opportunities so that it becomes easier to expand that entry into those disciplines and areas for everyone. And not just those who we know we need to target our interventions on those specific groups, of course, but I think we need to widen those pathways. And so some of the initiatives that I've seen that have worked in different areas is really having the opportunity to accompany many of these different groups in the spaces where they are. So going into the community, having them sort of pair up with these different disciplines, see what it looks like, help them to align the courses that they're taking, even in high school, so that they can apply and be successful into this curriculum. So it really starts very far upstream to the point where we're saying, well, we don't have enough representation. That didn't just start there. So we need to start sort of addressing it at all of those crucial milestones to get to the spaces where we can have a bigger sort of cadre of representation.
Yeah. And Anka, you mentioned people that might come with an advanced degree or be a nurse in their own country, so they've got all that valuable education and clinical experience, and yet it means nothing once they cross the border. What are the challenges for someone like that becoming a faculty, say?
I mean, for many, the first thing is the language, right? You come with that language. We teach vocational English, not just the regular English, but vocational English for the healthcare sector, for example, right? Mentoring, have someone that can mentor you. We used to have this nurse that would come to teach conversations with a nurse class, and it was a vocational class, but she would give them the tools of talking about diabetes and so on. So I think it's trying to understand what the barriers are and try to dismantle one by one, right? And yes, the first one is language, but then it's also access, like you were saying, right? Norwalk Community College is expensive, so getting enough grants that you can bring these people in. And Norwalk Community College is not a Stanford and it's not Bridgeport. How do you transport people, right? Talking about the social determinants of health. How do you make it, easy for people to dismantle all these barriers to have access to that? And once you do that, then you will start dreaming and of pushing people into faculty roles. But I think there are so many barriers yet for people to get there, right? And I think it's in all of us to work to dismantle those barriers.
Great. Next question.
Good afternoon. My name is Elaine O'Keefe, and I wanted to start by just giving my heartfelt appreciation to all of the panelists for the work that you do on health equity and racial justice. I worked in the public health field for many, many years. I continue to do so more on a volunteer level. And one of my frustrations in my lived experience in that profession is that we continue, and I mean this in no disrespectful way to our conversation, to devolve to the healthcare, which is a sick care system, to correct the problems that we know many reside outside of the healthcare system. While I believe wholeheartedly that the healthcare system has to contribute and should contribute, we're putting way too much money into a healthcare system that doesn't have the desired results. The conversation needs to also move outside of that, and I don't believe, in fact, I think it's perverse to think that our sick care system is going to solve those problems, or should. That is not where many of the problems reside. I won't take much more time, but after George Floyd's murder, one of the initiatives was to declare public health, to declare racism a public health crisis. And a lot of municipalities and other places tried to pass resolutions. Some did it successfully, some created commissions, and then the CDC followed and declared racism a public health crisis. But from my observation, many of those initiatives have not blossomed into real strategy or execution, and too often devolve back to looking at the healthcare system. So I guess my question is, and maybe it is an unfair question, but just my comment is, how do we also move the conversation, get people to acknowledge that racism is if not the driving factor, and to at least acknowledge that it exists, that it is a public health crisis, and that there are structural changes that need to occur outside of the healthcare system. Thank you.
Great question. Well, I'll ask you, Camille, like you've talked about systems changing. What impact did it have when you saw cities, states, the CDC declaring racism a public health crisis? Was that important? And yeah, has it had any impact?
Well, I think narratives are important, and I think that's exactly what we're talking about here, right? How do you transform narratives? Because the way we even speak about health, and I was referring to that earlier, is that we have to start to identify what it is exactly we're speaking about when we're saying these things around, inequities and root causes. We have to talk about them, excuse me, and health in ways that really center what the issue is. And so we recognize that health happens in homes, it happens in the communities, et cetera, but we talk about a system of health. And to your point, which I love so much, is that we know that it happens beyond these walls of this specific space. So it's up to us to talk about it in those ways, though. We don't abdicate the right to talk about health beyond just the hospital setting. We should be talking about it in all of those spaces. So I have seen small bits of change in the narratives around health. I haven't seen as much change around the narratives around racism in health. I think that's where we have growing edges to do, to be quite honestly, across the system. What I've seen working well to this point is to really take these health organizations and systems on a health journey. People are in different stages of this journey, and giving them a structured theory that works to say, listen, if you really want to do this work, these are the key milestones and steps you need to take. So something very practical and something that's actionable, and to the point of execution, absolutely. And so there is a journey. It's not a secret. It's been written about. In 2016, there's a white paper that's called Achieving Health Equity, and what are the exact steps that need to be done to achieve that. And so that can be adopted across settings and across systems, and it can be executed and followed like a recipe on how this can be done. So is the will there for people to do it, though? Is the commitment there to be able to say yes? And then is that commitment followed by the resources, what we've talked a lot about today? Is investment there? Has the board committed to taking action for equity? Is it embedded, not just in a strategy, but into action? So until we do all of those things, then we can start to say, yes, I have seen a change. I have seen it work in settings and collaborative work that we do across different targeted systems who are really, truly committed to doing this. But it hasn't been widespread in the ways that I think that we should expect to see.
Yeah, that's a great question. Do we have questions on this side too?
Hi, good afternoon. My name is Holly Hackett. I am a person with several disabilities and complex medical issues, and also a mental health diagnosis. And with acknowledging my privilege, I am still treated very poorly in the medical system because of a lot of different stigmas. So with keeping that in mind, I have like a 3-part question. The first question being, do you think that if perhaps we have more patient advocates in the hospital settings, specifically in the emergency rooms, for perhaps 24-hour shifts, having them covered, that perhaps there will be better care? And my second part question would be, do you think that maybe if we spoke to the residents coming in or nurses coming in personally, to give a personal voice and face to cultural competence instead of just reading about it, do you think that would help? And my final question is, do you think if we had a universal health care, sort of like an expanded and improved Medicare for all, would actually help this system be a little bit better?
Okay.
Thank you.
Okay. Pat, I'm going to let you take on as many of those as you can.
Yes, yes, and yes to all three. In terms of having advocates in the care setting, making sure there are some parameters around that could be very constructive for certain. So at the end, and I don't want to get too political in terms of a Medicare for all, we are spending twice as much per capita as other industrialized countries and getting poor outcomes. But our financing system is pretty different than a lot of those countries. And so sort of a commercial insurance system there are a lot of resources that are spent administering that system. And that's not impacting the health and well-being of anyone. Maybe the health and well-being of corporations that are doing this work. I think that is something, and there's a growing sentiment that we have to look at how we're administering our system. And Connecticut is actually thinking about some very progressive ways to reform. And I think that's fertile ground. Again, that's one of those things that makes a lot of people uncomfortable, but I think it has to be talked about.
That's great. About cultural competencies, I was delighted to see Linda's slide of all the pre-meds. And when I go to Stanford Health to provide training, I do it to the C-suite level, but also to the residents, right? And what I'm seeing that every year there are more and more diversity. And I love that part. I mean, we're closer to New York, and Stanford has 33% of the population is foreign-born, so there is a lot of diversity. But I love the fact that now we get invited. People are seeking that conversation about, you know, the diversity and being more brave about looking to get more competent, right, culturally.
Terrific. Next question.
Hi, my name is Laura Shulman-Cordera. Thank you all for being here. My question and comment is sort of going off of what the keynote speaker said earlier about how individual behavior change is not the solution. We still continue to talk about what we could be doing to fix either the patients to make them better advocates for themselves, or for the personnel to make them, you know, better informed about these issues and thus want to provide better, more culturally competent care. And we also continue to talk about businesses as sort of the solution for all of this. And so just changing the focus and thinking similar to what my two previous colleagues brought up, what can we do to harness the collective of all of us here in this room today who are all doing our small little pieces to kind of try to make our little bit of change in our little area that we can, again, focused on sort of funding programs and things like that, to actually harness us to come together and make legislative change so we can fix the systems and not continue to put people who are in marginalized communities into these systems. So that's my question.
Great question. You would like to take that one?
Yeah, I think part of what we have been talking about in one way, shape, or form is really doing something in a coordinated way, coordinated action, and that's what you're talking about. And it's being done. It's being done nationally. There's a Rise to Health Coalition for Health Equity and Racial Justice that is bringing to stakeholders across the ecosystem together around shared goals, aims, and specific collective action and activities. And that can be done at a state level as well. I've seen that done in different states by local collaboratives that have formed together and brought themselves and organized themselves in ways that they're able to say, okay, we're going to either work on specific health equity goals together, or we're going to work on them sort of in our own spaces, but come together to problem solve, to share ideas about what's working, what's not, to organize around policy and things like that. So there's nothing that precludes you from doing that here, and it may be being done already. There's alliances that exist. Those alliances can join other alliances and form bigger networks, share information, share resources, you know, share better practices of what's happening. So all of these things are going on, and I often want to say back to the group, this is something that you can do. Like, we're here, we're on the stage for a very finite period of time, but the responsibility and the ownership belongs to all of us in the room. So I would say, you know, what can you commit to together today to do that and then get organized around doing that? But there's a lot of great work. I've been hearing about it yesterday, today. There's great stuff going on in this room. And so how do you leverage that? How do you amplify that? And how do you sort of disseminate for scale and for impact?
And you have to do that very intentionally. And so it'll be up to the leaders in the room or those who feel, so called to pull that together, pull it together. And you can do that.
I think we have time for a few more questions.
Hi, I'm Mark Abraham at Data Haven. The keynote speaker today talked about the 30-year life expectancy difference across Chicago, and we have the same difference in Connecticut. One thing that drives that difference, like when looking at COVID, that was only like 10% of the difference in premature death. A lot of the main drivers are with injuries, so opioids, which have I think a 500% increase in opioid deaths among Black Americans in Connecticut recently, just over the past few years. Traffic deaths is a big one. We just had a toddler killed in Hartford last week, I think. And the other one is firearm injuries, which disproportionately affects certain communities. So I'm just curious, I haven't heard a lot of discussion around that. Is there kind of a rift between healthcare and health equity space and those injury prevention issues? Or do you see bright spots in your work where healthcare, health equity folks are trying to address those kind of big contributors to the life expectancy gap?
Great question. Anyone want to?
You can only hear pieces of it.
Oh, you could only hear pieces? Yeah, sorry, we had trouble hearing you. Could you encapsulate the question? Just very briefly, we only have a few minutes.
Sorry about that. To the front. What? Okay. Yeah, the question was just regarding that life expectancy gap. A large proportion of that is with injuries. So opioid deaths have skyrocketed, especially among Black Americans, firearm deaths, and then traffic crashes. So I'm curious if in the healthcare space, health equity, is there sort of a difference in that space and the injury prevention folks, or do you see bright spots in your work where health equity advocates, healthcare organizations are trying to address those major contributors to the difference in life expectancy?
So, anybody? Oh, okay, thank you for that. I heard that much better. What I've been seeing is there's been a lot of calls for action around specifically life expectancy and closing the gap, and as well around, there's a call around ARPA-H. I don't know any of you have heard of ARPA-H. It's a new initiative called the HEROES Initiative, and they identify very specific areas of disparity and wanting to get organizations, whether they're community-based, healthcare system across it, there's really no parameters around who can be involved to apply for those dollars, but I'm seeing a lot of coordination around calls to pull all of these minds and efforts together to start solving for that. So that's one very current bright spot that I know, and those areas that you identified, I know opioid was called out, violence specifically has been called out, and alcohol use has been called out very specifically to bring large-scale change and collaboratives together to address that very specifically with incentives to do that. So there's matching incentives for organizations to come together, and then it's matched at a government level based on the closer you get to achieving the gap closure.
Terrific. So we have about 5 minutes left, and I think I'm going to ask each of our panelists to talk about one thing, large or small, that they have seen working, that they are hopeful about, that could maybe transfer. And I'm going to take the liberty of sharing one of my own. I think you'll be hearing a lot more about this. Many people have been working to revise these clinical algorithms to determine how sick people are. And race has been used in them in very harmful ways. You may have heard about kidney function tests. And because of these mistaken notions from dating back to pre-Civil War science, as Linda might say, this notion that Black people are more muscular. So when their kidneys don't function as well, it doesn't mean they're sick. It just relates to their own physiology in their body. And so after 2 or 3 years of a lot of fighting among nephrologists who were saying, well, this equation's scientific, and we want to do no harm. They have finally overturned that. And there's no more use of race in determining if your kidneys work or not. And anyone who knows kidney disease knows there's huge disparities. And in the few months since that decision was made official, tens of thousands of Black kidney patients have gotten time on waiting lists that they should have had, sometimes 4 and 5 years. And I think they just released 3,000 Black patients have gotten kidneys in just this short time. So that's kind of a form of a reparation. And I think even if there's pushback, they're not going to go back and revise. I mean, it took them 3 years to change it. They're not going to go back on it. And so I think that's something that has really moved forward, and a lot more people will be alive because of that. So that's something I'm really excited about. And Pat, do you want to share something?
Yeah, we talked earlier about structure and incentives, and so I've been advocating for sort of advanced payment models that have equity embedded in their structure. And again, I talked about the fact that, that is uncomfortable because the unknown creates some insecurity, and while we're doing this work, we don't want to fracture the things that are working. So I think we need bold leadership to embrace structural change, and it has to be with people leading that effort that have credibility. People can talk about it, but if you're in a position where you could actually influence it, I think you have to step up and do it. So I'm trying to do that. And I think the other thing we're doing is, I said earlier, that there are organizations that are much closer to the ground that have been essentially ignored and under-resourced. So building an infrastructure around them to support their activity and to make sure it's integrated, so as we're going out there and identifying social needs, we know how to connect individuals that have those needs with organizations that are much more competent at doing it than kind of the traditional sort of hospital and healthcare system providers. So I think it's really important going forward.
Terrific.
I mean, piggybacking on that, Patrick, is the concept of building coalition, right? We have seen how the power of really collaborating makes really the work. It makes it with Husky for Immigrants. It makes it with, I'll give you an example. In Stanford, we have these collaboratives called the Beta Collaborative. And our mission is really to care of the health of Stanford residents. And there is a bunch of organizations on the table that have to do with health, that have to do with immigrants, that have to do, so it's how do you tackle all these issues from different angles? And that's what makes it powerful, right? Because otherwise you're gonna only do it through one, and it's not gonna get you very far. So I believe that what gives me hope is that, is those coalitions, right? Where you can generate talks, but also walk the walk.
Yeah, I agree. I've seen that too. And what gives me hope is the action part of it that goes beyond, as I earlier had said, admiring the problem. Like I've seen a lot of traction on the ground around the coalition building, the breaking down of the silos. We have more to do. We're not close to where we need to be, but I'm seeing that accelerate very recently, I'd say in the last year. And there is a lot of course, incentives to do that. But as well, I think there's a lot more openness and receptiveness and realization that, we can't do this alone. And we've been trying to do it alone for too long. And so I'm seeing a lot of more willingness to do things together, not as territorial around this is our space and, you do your stuff over here, we do stuff over there. So that really does give me hope, because I know that's necessary to do the structural and systemic change that we need to do. So that alignment, that coming together, the collaborations, that gives me hope.
It's terrific. Well, thank you. Thank you for this great audience, and the questions were terrific that you guys came up with. And I just want everyone to give a round of hand to this incredible panel.
Again, thank you to the panelists for this wonderful discussion. And what we are hoping for is that the conversation continues over lunch. We're about to have our lunch break, and we want you all to continue to figure out how you can work together. I think after listening to today, what we know to be clear is that we are living in an imbalance in a system that is inequitable really by design. So I know that there are some of us who have to work within this broken system, but there are some of us that can work outside of this broken system. And so how do we build strategies that are both from the inside and from the outside? How do we continue to make bold steps and actions towards dismantling, upending, and recreating and redesigning the system? I hear a lot, we heard a lot about racism being at the root of a lot of the issues, which we know to be true. We can't be afraid to have these conversations anymore. We don't have time for it anymore. People are dying because we've been afraid to have these conversations. And so we need to continue to talk about the root causes and again, figuring out how we undo this broken system. So we are encouraging you over lunch to grab your lunch, to come back, to have conversations about how we can all work together. As you are also getting your lunch, please know that we have a bookstore and Linda's book is available and signed if you purchased her book. So there are signed copies of her book that you can purchase if you are interested in that. So grab your lunch. We are going to continue the conversation. And the other thing I will say is we're going to thank Gail as well for taking all of our pictures throughout the day. And she will try not to catch you with your mouth open, but she is going to continue to be here to take your picture. And we really want to memorialize this day. And thank you all for being here. Thank you.